Good morning everyone. Today we are going to talk about juvenile nasopharyngeal angiofibroma. The juvenile nasopharyngeal angiofibroma is a benign aggressive tumor. It is rare tumor, though it is commonest of all the benign tumors of nasopharynx. And talking about its etiology, the exact cause is unknown, but it is thought to be testosterone dependent as the tumor is predominantly seen in adolescent males. And the patient have hematomous needles of vascular tissue in nasopharynx due to the incomplete regression of the first branchial artery, which under the influence of testosterone hormone will convert into angiofibroma. Moving on to the site of origin and growth, it is believed to arise from posterior part of nasal cavity, which is close to superior margin of sphenopalatine foramen, and it grows into nasal cavity, nasopharynx, pterygopalatine fossa, and other places as well. Now let's talk about its pathology. Grossly, it is sessile, bilobed, rubbery, and red, pink, or grey in color. And talking about its histology, it is encapsulated. It is composed of vascular tissue and fibrous stoma, and the vessels are thin-walled. There is lack of elastic fibers and smooth muscles that may lead to the uncontrolled bleeding. Now talking about the extension, the nasopharyngeal fibroma is a benign tumor but locally invasive, and it destroys the adjoining structures as well, and it may extend into nasal cavity, paranasal sinuses, pterygomaxillary fossa, infratemporal fossa and cheek, and in orbital regions and in cranial cavity. It can also extend up to the orbit, giving rise to the proptosis, that is frog face deformity, and it can also invade the cranial cavity, that is anterior cranial fossa through the roof of ethmoids or claviform plate, and medial cranial fossa through erosion of floor of middle cranial fossa. Moving on to the clinical features, it is seen almost exclusively in the males and in the age group of 10 to 20 years, and there will be profound, recurrent, and spontaneous epistaxis, and there will be progressive nasal obstruction and denasal speech as well, and conductive hearing loss and otitis media with effusion can also be seen due to the blockage of eustachian tube by the tumor, and the mass in nasopharynx will be firm, and digital palpation of the mass should not be done because it may provoke bleeding. And the other clinical features are broadening of the nasal bridge, proptosis, swelling of the cheek, and there will be involvement of second, third, fourth, and fifth cranial lobe depending upon the extent of tumor. Moving on to the diagnosis is made on the basis of history, examination, and investigations. And talking about the history, the patient will be young adult male, and there will be progressive nasal obstruction in that patient. There will be profound bleeding as well from the nose, and the features of otitis media with effusion can also be seen due to the blockage of eustachian tube by the tumor, and the fleshy tumor will be seen on the nasopharynx. And for investigations, we will do CECT, MRI, and X-ray. CECT will be done to know the extent of tumor, MRI is done to know the intracranial involvement, and X-ray is done in the lateral view to see the bow sign, that is anterior bowing of posterior maxillary antrum, and we will not do any biopsy. And the differentials for this angiofibroma could be carcinoma of the nasopharynx, antroconal polyp, adenoids, teratoma, rhabdomyosarcoma, meningioma, and hemangioma. Moving on to the treatment of nasopharyngeal angiofibroma, first of all, we are going to do pre-operative reduction of tumor vascularity by embolization of feeding arteries by using gel foams, by giving estrogen therapy, that is diethyl stilbestrol, and by the use of the medicine, that is flutamine, which is a testosterone receptor blocker, and by doing pre-operative radiotherapy and cryotherapy. And the various methods of treatment are surgery, radiotherapy, chemotherapy, and hormonal therapy, and management for recurrent tumors. Now talking about the surgery, surgical excision is the treatment of choice, and surgery can be done by adopting the following procedures, and that is transpalatine plus sublabial, that is known as the Sardona approach, and lateral rhinotomy with medial maxillectomy can also be done via facial incision, and we can do also the endoscopic removal of the tumors, which operation can also be done, and intracranial and extracranial approach can also be adopted. Moving on to the radiotherapy. Radiotherapy has been used as the primary mode of treatment, thus avoiding surgery, and a dose of 3000 to 3500 CGY is given in 15 to 18 fragments and is delivered in 3 to 3.5 weeks, and the response is not immediate and the tumor regresses slowly in about 1 year and sometimes even up to the 3 years. And moving on to the chemotherapy, it is done for very aggressive tumors and for recurring tumors as well. And the combination of doxorubicin, vincristine and dacarbazine can also be given for chemotherapy. Since the tumor occurs at young males in puberty, so hormonal therapy can also be given as primary or adjunctive treatment. And moving on to the management for recurrent tumors, first of all, observation can be done since the tumor may regress spontaneously. And if even after revision surgery, if it reoccurs, then radiation can also be given. Thank you.